Welcome to the 2025 American Academy of Neurology Annual Meeting Top Science Press Conference. The American Academy of Neurology is the leading voice in brain health as the world's largest association of neurologists and neuroscience professionals with over 40,000 members. This year, the meeting is being held in San Diego and online April 5th through the 9th with more than 12,000 attendees from around the world. My name is Andrew Imholt, and I will be your host today. At this year's meeting, more than 3,200 scientific abstracts are being presented by researchers sharing the latest scientific advances in brain disease. You'll hear about 3 of those today. Thank you, members of the press, for joining us. Today, Dr. Paul George will present his choices for top science. Dr. George serves on the faculty at Stanford University as a vascular neurologist in the Department of Neurology and Neurological Sciences. He is a physician scientist focused on caring for neurology patients and improving neural recovery therapies. As faculty, he helped create a multidisciplinary stroke recovery clinic at Stanford. Dr. George is chair of the American Academy of Neurology's Science Committee, and it is the AAN Science Committee that oversees the selection of the science being presented at the AAN Annual Meeting. Dr. George will be joined by the authors of 3 abstracts he has selected to feature at today's press conference. Dr. Rajesh Pahwa of the University of Kansas Medical Center in Kansas, Dr. MaryAnn Mays of the Cleveland Clinic in Ohio, and Dr. Robert J. Fox, also of the Cleveland Clinic in Ohio. After each presents their abstract, Dr. George will ask the author a few questions. We will then take questions from journalists. To ask a question, post your name and news outlet in the Q&A. If called upon, we'll ask you to unmute yourself and ask your question. Use the chat function only if you are having a technical issue. I would now like to introduce Dr. Paul George, who will share some opening remarks about this year's AAN annual meeting as well as about his selections for top science. Welcome, Dr. George.
Thank you, Andrew. It's my pleasure to welcome everyone to the AAN's 2025 Top Science Press Conference. I'm so excited to ring the opening bell on the amazing science that will be presented at the meeting this year. This meeting will be a wonderful gathering of our community to celebrate and discuss scientific advances. Our community and the importance of science is ever more important in these current times. The importance of science to improve care for our patients has never been more front and center than at this year's annual meeting. We had a record number of abstract submissions, indicating the importance of science in neurology and the progress in our field. Our clinical trial plenary contains the results of phase 3 trials presenting the latest impactful advances across neurology. The neuroscience in the clinic sessions help explain how we bring this science to our patients, and the platforms and posters highlight the rapid advances we are seeing across neurology. This excitement is only added to by our celebration of the NIH's National Institute of Neurologic Disorders and Strokes 75th anniversary. The NINDS have partnered with the AAN over many years to tackle and improve treatment of some of our toughest diseases. Without these important advances, we would not be where we are today in terms of treating our patients with neurologic disease. For this year's Top Science Press Conference, we are highlighting researchers' abilities to advance our understanding and approach difficult diseases with new technology and methods. A fitting theme is increasing brain resilience through scientific discoveries. Brain resilience is an important part of brain health that allows the brain to maintain function even in the setting of disease. These abstracts represent the use of new technologies to enable new ways to treat neurologic conditions, improving brain resilience. Our first presenter will discuss how they used a novel AI electrical stimulation technology to improve the treatment of the common neurologic disorder of essential tremor. The ability to tap into our body's own electrical signaling offers exciting new avenues to modify disease. The second guest today will present how they leveraged a non-invasive technology to improve migraine treatment. The potential of non-pharmacological methods to treat headache offers new benefits, especially as technology advances to make these more readily available. Our final researcher for today will discuss a truly exciting advance in treating people with non-relapsing progressive secondary MS. People at this disease stage currently have limited options, and this new advance offers a potential breakthrough for treating MS in this progressive stage. All of the research we discussed today represents new technologies and advances that can improve brain resilience in the setting of neurological disease. So I can't wait to get started and hear from the investigators.
Thank you, Dr. George. I would like to introduce Dr. George's first guest, Dr. Rajesh Pahwa of the University of Kansas Medical Center. Dr. Pahwa, please turn on your video and audio at this time. Dr. Pahwa will present his abstract titled Tranquil, Pivotal Study of the Felix Neuro AI Wristband in Patients with Essential Tremor. Dr. Pahwa has disclosures which can be found on AAN.com. Note that this late-breaking science is embargoed until 8:45 p.m. Eastern, 5:45 p.m. Pacific Time, Tuesday, April 8th. Please do not publish stories on this research until the embargo lifts. Welcome, Dr. Pahwa. Please share with us a summary of the findings of your research.
Thank you. And I would like to also thank the Academy and Dr. George for selecting us to present this exciting data. We performed a double-blind, randomized, sham-controlled trial, and our results show that a new medical device, which is a non-invasive peripheral nerve stimulator, successfully improved essential tremor. Essential tremor is among the most common movement disorders, affecting up to 2% of the people worldwide. It is characterized by an involuntary rhythmic movement. So we all have experienced a little bit of tremor when we are anxious, when we are scared, when we are giving a presentation. However, in patients with essential tremor, this is present most of the time, and in a large number of patients, it can affect their daily activities. Essential tremor mainly is present in the hands and the arms, but can also involve other regions such as the head and voice. When these movements interfere with their daily activities, we often use oral medications to help the tremor, and the current medications often are unsatisfactory. The pathophysiology of tremor is believed to involve a brain circuit that includes the ventro-intermediate nucleus of the thalamus or the VIM nucleus. Deep brain stimulation and focused ultrasound have shown that interruption of activity in the VIM can reduce tremor, and these treatments have been very effective, however, require surgical intervention. It is believed that the electrical stimulation of the peripheral nerves in the wrist can also modulate the activity in the VIM, and this effect has been reported with another device that is currently in use. The device used in the current study, which significantly improved tremor, is different from the device that's already in use. The current device uses a cloud-based AI algorithm to monitor the tremor and adjust the stimulation in real time based on patients' activity and predictive analytics. It is directed towards all three major nerves in the forearm, and it is designed to be worn all day long. This study enrolled 125 adult patients with essential tremor at 12 sites in the United States and China. 2/3 were given the active treatment, and 1/3 received sham device. Patients' characteristics were balanced between the two groups. After baseline measurements and fitting of the device, the participants were told to wear it during waking hours for 90 days with regular clinical follow-ups during this time. The primary outcome at 90 days was a composite measure called the TETRAS MADL that is basically involving modified activities of daily living score. This combines 10 activities of daily living and 2 clinical assessments of tremor. At 90 days, MADL was reduced by 6.9 points in the active group and 2.7 in the sham group, which was both statistically and clinically significant. Both the clinicians and patients were more likely to report improvement in symptoms at the end of the study in the patients that received the active treatment. Quality of life was also improved more in the patients who wore the active device. The most common adverse-related events were mild skin irritation, which often did not require any treatment. There were no serious adverse effects. Thus, This AI-driven wearable device was safe for use during the day and effective in reducing the symptoms of essential tremor. Thank you.
Thank you, Dr. Pahwa. One question that I had was that some of the patients in the trial were on medications as well. Do you see these AI-driven technologies as reducing the need for medication or augmenting medication effects?
So in this trial, we included patients who were taking their current tremor medications. Right now, there are only two medications which we report as being the initial drugs to be used for essential tremor, which is beta blocker, propranolol, and primidone. We still believe that these would be the drugs that would be first tried for tremor. And if there's an inadequate response or patients cannot tolerate or don't have response to the oral medications, that's when we would recommend using the current device.
Great. Yeah, I think one of the really neat parts about this study was the use of AI to sense the body's own electrical signals and modify the therapy. Do you see this approach being used for other movement disorders or neurologic diseases where you get a patient's baseline or their own signals and then use that to treat them?
I think that is going to be what the future will hold. And I think this is very important, like for essential tremor, if the patient is sitting and not doing anything, they don't have any tremors. So obviously you don't need to continuously stimulate them. When the patient is performing certain activities, that's when the tremor gets activated. And that's when it would be ideal for AI to pick up and provide stimulation. Similarly, different activities may cause tremor to be severe or less severe. And I think that's where it'll improve. I think in other movements that we also see as we get other devices, I think that would be the best way to treat it rather than have a continuous stimulation at a fixed rate to improve their movements.
Wonderful. One final question here for me was that, with these wearable devices, there's maybe a limitation with how willing patients are to wear them throughout the day. Do you see any advances in the technology that would make it easier to wear the devices, or did you see any signal for that in your study?
Yeah, so I always say, the prettier the watch is, the more likely people are going to wear it. And if we compare, the wearables today compared to what we had a few years ago, they have improved, they have gotten smaller, and they have gotten sleek. So I also agree with wearable devices. As the devices improve both in the way it looks and the way it provides therapy, I think people will wear it more often. In our study, majority of the patients, over 75 of them, did use the device regularly over a period of 90 days. So I think this is something, and remember, this was sham control. So there were people who are not benefiting it with this therapy. But I think if the patients benefit from therapy, they will continue to wear this device because it is going to help them.
Thank you. And look forward to hearing some of the questions from the journalists now.
Thank you, Dr. George and Dr. Pahwa. Journalists, this is Renee Tessman from the annual meeting press room team. Next, we will take questions for Dr. Pahwa. Journalists, to ask a question, please post your name and publication in the Q&A. You do not need to post your full question, just your name and publication. If I call on you, you will receive a notification to unmute yourself and ask your question. While your video will not be activated, the audio of your voice will be live. Do we have any questions from journalists today? Well, Dr. George and Dr. Pahwa, I am not seeing any questions. Journalists, if you do, we do have one now. Stephanie Viguier-Llewellyn from Helio, if you would like to unmute yourself, you may ask your question.
Hi, thank you so much for answering my question. I was just wondering about the cost of this technology. Is this something that patients would be able to afford?
So again, we do not yet have a price on this technology. This is going to be a medical device. So we believe Medicare and the insurances will cover the device. And of course, just like other devices that are already available for other conditions, this would be stuff that would be paid through the insurance company.
Okay, thank you, Stephanie. If there are journalists who have other questions today, you can either put them in the Q&A or email us at media@aan.com, and we will send them to Dr. Pahwa for responses. Thank you very much, journalists.
Dr. Pahwa will be presenting his findings at the late-breaking Science 2 session at the AAN Annual Meeting. This abstract is embargoed until 8:45 p.m. Eastern Time, 5:45 p.m. Pacific Time, Tuesday, April 8th. Thank you, Dr. Pahwa. We appreciate you sharing your research with us today. I would now like to introduce Dr. George's second guest, Dr. MaryAnn Mays of the Cleveland Clinic. Dr. Mays, you may turn on your video and audio at this time. Dr. Mays will speak about her abstract titled, My Helper Transnasal Cooling for Acute Migraine Treatment, a prospective, double-blind, randomized, sham-controlled, decentralized dosing study. Dr. Mays has disclosures which can be found on AAN.com. Note that this abstract is late-breaking science and is embargoed until 2:15 p.m. Eastern Time, 11:15 a.m. Pacific Time, Monday, April 7th. Please do not publish stories on this research until the embargo lifts. Welcome, Dr. Mays. Please share with us a summary of the findings of your research.
Well, thank you so much. And thank you to Dr. George and the AAN for allowing me the opportunity to share with you today the findings of our study, My Helper Transnasal Cooling for Acute Migraine Treatment. My Helper is an exciting, non-invasive, drug-free neuromodulation device designed to treat migraine by targeting the sphenopalatine ganglion, or SPG, a nerve bundle which is located behind the nasal passages, which is involved in migraine pathophysiology. Using dry, room temperature air, My Helper elicits local cooling of the nasal cavity, which calms or inhibits the SPG, relieving migraine pain and the need for medication. There's a critical need for alternative acute migraine treatments as many patients experience inadequate pain relief, intolerable side effects, or contraindications to existing therapies. Neuromodulation is an expanding field in headache medicine, and multiple FDA-approved devices are available for migraine treatment. My Helper offers a safe, effective, and accessible option using as a standalone treatment or with other existing therapies to help reduce pain of migraine and decrease reliance on medications, including opioids. Our trial included 172 adults aged 18 to 65 with episodic migraine, with 128 being treated with My Helper. A subset of these participants were included in the final efficacy analysis across dosing groups. The primary goal was to determine the most effective dose for migraine while still assessing the efficacy, safety, and tolerability. Participants self-administered the treatment at home within 1 hour of migraine onset for 15 minutes and were randomized to one of the 3 dosing arms, 4, 6, or 10 liters per minute, or sham treatment. The primary endpoints were pain relief and pain freedom at 2 hours, and additional measures of tolerability as well as sustained pain freedom for up to 24 hours. The study found that the 10 liters per minute dose was the most effective, with approximately 47% of participants achieving complete pain freedom at 2 hours compared to 16% in the sham group. This difference was statistically significant. Additionally, around 71% reported pain relief at 2 hours compared to 56% in the sham group, though this difference was not statistically significant. And approximately 41% had sustained pain freedom at 24 hours without the need to take rescue medications, compared to 16% in the sham group. Importantly, this device was well tolerated and there was no treatment discontinuations or serious safety events. With 37 American affected by migraines, the condition ranks as the second leading cause of disability globally. So clearly there is a need for effective, safe, and drug-free treatments. My Helper represents an innovative step in neuromodulation, providing this safe and well-tolerated solution for those seeking better migraine relief. Thank you for the opportunity to discuss this study.
Thank you, Dr. Mays, and congratulations on your exciting results. I was wondering if the therapy was effective only for migraine types of headaches, or if there are other types of headaches that may benefit from a similar type approach.
Yeah, that's an excellent question because I think patients, regardless if they have migraine or tension type, cluster headaches, even trigeminal neuralgia, they are also looking for additional alternative options. And although the studies have been focusing on migraine currently, there are future plans to include other headache disorders, as well as kind of globally broadening it to both pain and as well as mood disorders.
Wonderful. I liked that this study used non-pharmacological approaches to migraine, and maybe even under the biofeedback umbrella. Are there other areas outside of maybe temperature that you think could be effective for treating migraines as well, kind of in that same type of approach?
Yeah, definitely. So there are currently some neuromodulatory devices that stimulate the supraorbital nerve electrically, the occipital nerve. We are using transmagnetic stimulation in the occipital lobe to reduce migraine. So we're definitely expanding, and there's also an external vagus nerve stimulator that's being used. So there's different areas that are important in the pathophysiology of migraine that we're attempting to use in patient, and it's a great alternative. The one disappointing fact is the cost of these devices sometimes.
Right. I guess one other thing, as far as maybe a limitation from what I've seen, that's kind of presented out there, these devices are something maybe you would envision in your room or something at home. Are there efforts to make this a kind of more miniaturized, or a kind of a treatment that you can take with you and use wherever you may be when your migraine hits?
Yeah, that's an excellent question because, of course, we never know when migraines are going to hit. And so you want to have a device that you can take anywhere with you. The device now is fairly portable. It's about the size of a small sleep apnea machine. But this is kind of the prototype, and there's definitely interest in making smaller versions so that you could take it with you, throw it in a bag, and use it in a kind of a handheld device. And then the company is also looking, knowing the cost of these the neuromodulatory device, really to make this much more accessible for patients, much less than a lot of the current acute treatments available on the market. So even with some smaller startup costs, I think hopefully they're planning to market this by 2026.
Wonderful. And now happy to hear some questions from the journalists.
Thank you, Dr. George and Dr. Mays. We will now take questions from journalists. Journalists, please post your name and news outlet in the Q&A, and we will call on you. If we call on you, please unmute yourself. Megan Brooks from Medscape, you may unmute yourself to ask your question.
Oh, hi there. So my question was, did they take any other medication while they were treating the migraine attack? Were they on, did they pop anything else while they were using this device?
Yeah, that's important to know to really see the efficacy of this device. So they were not allowed to take any medications at the time of onset within that hour of migraine onset, but they were allowed to treat with a rescue medication afterwards if needed to. But again, 43% remain pain-free for that 24 hours without needing to take the rescue medications. They were allowed to stay on preventative therapies.
Thank you.
As long as they were stable.
Thank you, Dr. Mays. So seeing no other questions, we will move on to the next presenter. You can put your questions in the Q&A at any time, put your name and news publication, and we can get those to either the presenters who have already presented or to upcoming. Actually, we do have one more journalist. So Cesar Pescari, you may unmute yourself and ask your question. Cesar not unmuting? Okay. I can ask Cesar's question. He asks, is there any risk of abuse with this device?
No, it has not been studied for that. That's an excellent question. Now, interestingly, the cooling effect is very pleasant and relaxing for individuals, but there's been no associated risk of abuse known to date. So,
Okay, thank you very much, Dr. Mays. And
Thank you.
we do have one more question, actually, from Paula Dumas. Paula, if you would like to unmute yourself and ask your question, you may do so. Okay, she's not unmuting, but I can ask the question because she put it in there. Were the subjects episodic or chronic migraine patients?
Yes, these were all episodic migraine patients. They did include migraine with and without aura, but they did not separate them in regards to who responded with regards to efficacy.
Okay. Thank you very much, journalists. Andy, we can move on to the next presenter.
Thank you very much.
Thank you, Dr. Mays.
Dr. Mays will be presenting her findings as part of the AAN Annual Meeting session titled Late Breaking Science 1. This abstract is embargoed until 2:15 p.m. Eastern Time, 11:15 a.m. Pacific Time, Monday, April 7th. Thank you, Dr. Mays, for joining us today. We appreciate you sharing your research. Our third guest is Dr. Robert J. Fox of the Cleveland Clinic. Dr. Fox, you may now turn on your audio and video. Dr. Fox will be speaking about his abstract titled Tolebrutinib versus placebo in non-relapsing secondary progressive multiple sclerosis, efficacy and safety results from a phase 3 Hercules trial. Dr. Fox has disclosures which can be found on AAN.com. This abstract is no longer embargoed. Dr. Fox will be presenting the findings of this abstract today, but please know he will also be presenting new data on this research at the AAN Annual Meeting's Clinical Trials Plenary Session on Tuesday, April 8th. Dr. Fox, please share with us a summary of the findings of your research featured in this abstract.
Well, thank you very much for the opportunity to join you today. For over 30 years now, the story of therapies in multiple sclerosis has been one of the haves and the have-nots. More than 20 therapies are approved for MS, but these approvals have focused mostly on relapsing MS. No therapies have been approved for secondary progressive MS without relapses, so-called non-relapsing secondary progressive MS. This form of MS occurs later in the MS disease course and is characterized by gradual, little by little worsening of neurologic symptoms. Up to half of people with MS have non-relapsing secondary progressive MS, so treatments for this form of MS represents a major unmet need. Bruton's tyrosine kinase is a naturally occurring enzyme that is involved in the function of immune cells. Inhibitors of BTK were first developed years ago to treat blood cancers, but only recently have been studied in MS, where they are thought to alter the function of specific immune cells, including immune cells within the brain. Tolebrutinib is an orally administered BTK inhibitor that can penetrate the brain at relevant concentrations that are thought to be helpful in fighting inflammation within the brain. The Hercules trial evaluated tolebrutinib in non-relapsing secondary progressive MS. Patients were enrolled from around the world and were randomized to receive either tolebrutinib once a day or a matching placebo. And then participants were followed over several years. The primary outcome was progression of disability that was sustained for 6 months or longer. Additional outcomes included other disability measures, MRI measures, and of course, safety. Over 1,100 patients were randomized, and about 77% of subjects in each treatment group completed the trial. Those enrolled were typical of non-relapsing secondary progressive MS patient population, an average age of about 49 years, almost 2/3 were women, and a median of over 7 years since the last relapse. The primary outcome of the trial was met. There was a 31% slowing of disability progression as measured by the 6-month confirmed disability progression outcome. Several secondary outcomes were positive as well. Turning to safety, there were a few notable safety observations. The proportion with serious treatment emergent side effects were a bit higher among those receiving tolebrutinib, 15% versus 10.4% of placebo. The rates of some infections was a little higher with tolebrutinib, including COVID-19 infection, nasopharyngitis, and influenza. Importantly, the rate of liver irritation, as measured by liver enzyme elevation, was increased in those receiving tolebrutinib. About 0.5%, or to put another way, about 1 in 200 patients who received tolebrutinib had a very high elevation in liver enzymes, more than 20 times above the upper limit of normal. One of those patients progressed to liver failure and unfortunately died following liver transplant, which emphasizes the seriousness of that safety issue. All of those cases with a very significant elevation of liver enzymes to 20 times upper limit of normal or higher, they were all observed in the first 3 months of treatment, which provides a focused area for very close monitoring. In summary, the Hercules trial found that treatment with tolebrutinib slows the progression of disability in non-relapsing secondary progressive MS, which is very exciting because this is the very first time we have identified a treatment that is effective for this form of MS. There are safety concerns, particularly potential liver injury, and these will require careful counseling of patients and close monitoring for treatment. But finally, a bright day has come for the have-nots with MS, those with non-relapsing secondary progressive MS.
Thank you, Dr. Fox, and really exciting work, as you mentioned, in a part of the disease that hasn't had good therapy. So congrats on that. One question I had was the timing to start this. Obviously, you would hope to prevent progression when people have moved on from the relapsing remitting and not have to wait a period of time. Are there thoughts of, was this the right timing to start the medication, or are there biomarkers that you can follow that would give you some indication of the timing of starting this medication?
Yeah, we don't know when progressive MS starts or the secondary progressive aspects of MS starts, but we think it starts very early. And I'll just cite results from a partner trial, the Gemini 1 and Gemini 2 trials in relapsing MS, which did not find a reduction of the annualized relapse rate. And that trial was compared to an active comparator, teriflunomide, but it did find a slowing of disability progression compared to teriflunomide, which suggests that the earlier the better, perhaps, in terms of when this pathology starts. That although tolebrutinib did not reduce relapses compared to teriflunomide, it did slow progression, pointing to very early when this progression starts. Now, how to balance this drug with other MS therapies? It hasn't been combined with other standard MS disease modifying therapies, and it's not highly effective at reducing the relapsing MS pathology, as evidenced by it didn't beat an active comparator, teriflunomide. So we're still figuring out exactly the best time to start this drug. But I would point out that this trial enrolled patients up to age 60, which is on the older end of the spectrum of our MS trial population. We will be interested in understanding, does this help patients even older? And we'll have to design and conduct additional trials to look at even older patients.
Thank you. The immune system plays such a large role in other neurologic diseases as well. Do you envision that this approach could have effects in other neuroimmune diseases or other neurologic diseases when it affects the glia and other microglia and other immune responses?
Yeah, it certainly can. We do know that this drug gets into the brain, and we do have a growing sense that whatever is driving progressive MS, it's probably within the brain. And so it's very possible that other immune, particularly autoimmune disorders within the brain, may benefit from this drug. And we just have to apply it to those other conditions and see what it finds.
If you had to pick one, do you have one in mind that you think would be most exciting to explore next?
It's hard to say, but perhaps neurosarcoidosis would be an area which is a tough disease for treatment right now, but I think would be a target, and perhaps some other autoimmune encephalopathies or encephalitis disorders, some of the paraneoplastic syndromes, or maybe neuromyelitis optica. But all of those are different immune pathologies. So I'm not sure this will be the panacea for all of them, but we probably need to start with some of the preclinical models and see if there's evidence for activity.
Yeah, exciting. You mentioned some of the serious side effects. Now, having had that data and done the studies, are there ways, you had mentioned early monitoring and counseling, are there ways that you think we can approach to limit some of these side effects, either infection or the liver disease?
Well, the important aspect of the liver irritation, particularly the very severe liver irritation, that 1 in 200 very high elevation, it's not generally been seen in the cancer patients, which is surprising. And we've seen it in many other BTK inhibitors applied to MS trials. So this may be something that's idiosyncratic for MS, and in almost all cases, and perhaps all cases, across the different diseases, across the different BTK inhibitors, they're all seen in the first 3 months of treatment. So that suggests to me that patients walk into treatment with the predisposition. We're just not smart enough to figure out who is predisposed to get this. So if we can figure out who is predisposed to get this very severe liver irritation and exclude them from treatment, that would be a great thing. And that would then increase the safety of the patients who do receive this. But we're still searching for that signature of patients who are going to have that very high elevation. Now, the good news is, as long as we recognize it and tell patients to stop treatment, it appears, at least to date, that it will resolve on its own. So there's no magic treatment that we have to make sure we get to the patient in time. We just have to say, stop taking that drug, and then let the body recover. So that's good news, in that we just have to identify it with very intense monitoring in the first 3 months. So weekly liver enzyme monitoring is what this trial had done, and I think probably will be what is recommended if this comes out for clinical use.
Great, that's promising. Thank you, Dr. Fox. I'm excited to hear what some of the journalists have to ask.
Thank you, Dr. George and Dr. Fox. We will take questions from journalists in the Q&A. And journalists, if you want to post your question in the Q&A, in addition to your name and news publication, I can read your question for you as well. Okay.
I hope I'm not the only one without a question. I'll make me feel bad.
Oh, but I think you will have plenty of questions at the annual meeting when you present new data, Dr. Fox. So thank you.
Looks like Judy George is going to save me here.
Oh, is Judy asking a question? Okay. Judy, if you would like to ask a question, you may unmute yourself.
Can you hear me?
Sure can.
Okay, great. So you mentioned the Gemini trial that you didn't see a decrease or change in relapses with this treatment. What is this telling us about multiple sclerosis?
Well, there's been a growing sense that what is driving the relapsing pathology, the relapses and the new lesions on MRI, is relatively different and separated from what is driving the progression aspects, the gradual little by little worsening that our progressive MS patients report. I think it's the relapsing pathology sets up and starts the cascade, but that cascade then is relatively separate and independent from that relapsing pathology. So to me, this emphasizes the growing sense that there are two different pathologies in MS, the relapsing pathology and the progressive pathology. We do want to stop the relapsing pathology, but just by stopping that doesn't prevent what has already been triggered with the progressive MS pathology. So it really reinforces the separateness of the pathologies, although the one, I think, does trigger and set up the cascade for the other. But it does emphasize that these are different aspects, different pathologies that will probably need somewhat different treatments, at least based on what we know so far.
Right. Right. And that theory or that logic then may explain why we're not getting, why we're not been able to solve progression with the treatments that are
Right.
effectively
I mean,
relapse.
we had for 10, 15, 20 years taken our relapsing therapies and just thrown them at progressive MS, and
Right.
they uniformly have not helped. And so this explains why. I would highlight that the Gemini trial was compared to an active comparator. So it's not
Right.
that this drug doesn't do anything on the relapsing pathology. It just
Okay.
didn't do anything better than what teriflunomide or the trade name Ubagio does.
Right. Good. Thank you.
Dr. Fox, we do have one more question from Cesar Pecorisi. He asks, if we can consider this drug a first choice treatment for this form of MS, a problem could be the tight diagnosis of the patient.
Well, this would be the only treatment if this does become approved. This is the only treatment we have for secondary progressive MS without relapses. So just by nature of we don't have any treatments, this would become the primary, the first line treatment. Now, we do have to recognize progressive MS. And so sometimes we're not as good as neurologists at recognizing that. But the patients tell us when they have progressive MS. It's a gradual, little by little decline in the neurologic function. Most commonly manifests as an early fatigue of walking, but can manifest as arm dysfunction and cognitive dysfunction as well. So we do need to learn to recognize it. And again, going back to the Gemini trial, it highlights that probably there's progression going on underneath the surface during even the relapsing phase of the disease. We're just not as good at seeing it and knowing when to start treatment.
Thank you, Dr. Fox. So journalists, for those who we didn't get to today, please put your questions in the Q&A and we can send them to Dr. Fox for responses. Thank you, journalists.
Dr. Fox will present this new data beyond this abstract at the AAN Annual Meeting Clinical Trials Plenary Session on Tuesday, April 8th, starting at 9:15 a.m. Pacific Time. Registered press will be able to watch the presentation live in person or online. If you would like to register to attend the AAN Annual Meeting online and watch Dr. Fox's presentation, we have extended the deadline through the end of day today. Please email media@aan.com. Thank you, Dr. Fox, for joining us today. Dr. George, would you like to share some closing remarks?
Thanks, Andrew. I just want to thank again Dr. Pahwa, Dr. Mays, and Dr. Fox. I think the research across the field of neurology has been just picking up steam over the years as we have more ways to treat our patients. And hopefully this gave you whetted your appetite here for some of the great science we're going to see at our annual meeting. It truly is jam-packed with great advances across our field and a wonderful time just to connect with community and discussion. So thank you again, everyone from the Science Committee.
Thank you, Dr. George. Journalists, email our annual meeting press room team today at media@aan.com with any other author questions or to register by end of day today to attend the AAN Annual Meeting online. On behalf of the American Academy of Neurology, thank you, Dr. George, as well as Dr. Pahwa, Dr. Mays, and Dr. Fox for sharing their research today. And thank you, journalists, for attending the AAN Annual Meeting Top Science Press Conference. For more information about the American Academy of Neurology and the 2025 AAN Annual Meeting, visit AAN.com. Thank you.